Thank you so much, Susan. It's a pleasure to be here. And of course, I wouldn't be here without the absolutely generous support of Zoometica to be able to sponsor this webinar, to really be able to give us the opportunity to talk through this presentation today. For everybody who's joining me in real time today, I have the webinar chat open on my end. I'm always really curious whenever I'm logging in and I don't have the pleasure of seeing all of your faces. Do me a solid, throw a quick comment in the chat. Let me know where you are actually joining from today. That gives me confirmation, number one, that you can hear me, number two, that you're out there, and it lets me know that I can see your comments as they're coming through. So hopefully that works. Is the chat enabled, Susan?
The chat, unfortunately, is disabled. However, we can put messages in the Q&A box. So just put them over in that little area.
Let me open that up instead. Thank you. I should have asked that ahead of time. So that is perfect. There they come. We got Denver, New Hampshire. I see Seattle popping in there. Amazing. Virginia, Kansas City, the UK. Welcome, welcome. It's late. It's late in the UK right now. Palmetto, Florida, Richmond, Pennsylvania, West Virginia, Illinois. We're really representing today. Connecticut, California. Amazing. Thank you. And I got a Portlander in the house today as well. Hello, Dr. Tokar. I love the fact that we've got so many people from so many places, including my home state of Minnesota. I see on the list there. Thank you all for joining me. As we get started, I will keep that Q&A box open. So if you have questions throughout the conversation here today, by all means, go ahead and throw them in there. I'll do my best to grab them as we go through. We'll get those curated and we'll see where this takes us today. I know we're getting started just a few minutes after the hour, so I'll do my best to get through the information and give us some time at the end for questions. Where I want to start today on this topic of prescribing for separation anxiety, how do you decide, is really thinking about what is it that we're treating? Right, so the recap on separation anxiety, meaning I am not going to do a deep dive on what separation anxiety is or isn't. I'm coming in with this today sort of with the kind of the trust that you've got at least a basic fundamental understanding of what separation anxiety is, one of those problematic fear, anxiety, emotionally driven behaviors that are happening exclusively within that separation, isolation condition, right? That's what we're talking about there. And of course, we know that there are so many signs: destruction, vocalization, elimination as some of the big ones, some of the cardinal signs, and then lots of other dogs who do a lot of other things, whether that's rearranging the furniture to inhibiting their behavior and perhaps just being anorexic or inappetent during the period of stress. We also know that there's a lot of different management and training options and the opportunity here for supplement or medication use. Now, that's going to be the focus of our conversation today, but before we get too far into that, I always have to put that quick little caveat in to say, you think it's separation anxiety, make sure you verify. Especially in this day and age, getting video is no longer, as I tell my clients, it's no longer a request or something that would be nice to have. If I am going to diagnose your dog with separation anxiety, I need to see video of what they look like when they're alone. Ideally, I get video of the departure sequence and the return sequence as well, but I absolutely need to know what your dog is doing when they're home alone and how does that vary from their normal baseline. There are too many other things out there that can look like separation anxiety, but aren't. And so I need to know before I go down that medication or prescribing pathway that I'm actually prescribing for the right condition. Otherwise, it may change everything about the clinical response to treatment. Now, as we start thinking about those cases with separation anxiety, assuming we've done our due diligence and we've confirmed the diagnosis, I use this next little sort of timeline or flow chart as a way for me to kind of organize my thoughts, both in terms of the questions that I'm asking to owners, as well as where that information is going to impact my prescribing habits. So in the first case scenario here, we're talking about the owner being present, right? And if we think about this whole timeline from the perspective of the animal, the owner is present, the owner leaves, The owner is gone, the owner returns, the caregiver is present, they leave, they're gone, they return. That from the animal's perspective, they're going through these different time points over and over and over again, assuming it's a caregiver who truly needs to leave their animal home alone and they've not been able to fully suspend those departures as part of that anxiety management strategy. But when we look at this first condition, we look at the owner being present. Some of the questions that I'm trying to get answered in my brain, not only to make sure that I've got the right diagnosis, but also to make sure that the support I'm providing is appropriate for that animal, is I'm asking questions actually about things that aren't separation anxiety. Are there other concerns? When you're there, do we have other concerns of noise phobia or noise sensitivity? Do we have other fear or anxiety conditions? Is there a generalized anxiety component? Is there a level of reactivity or hyperarousal, or what else is there? The reason this becomes important is that if I'm thinking about a dog who, quote unquote, only has separation anxiety, and that owner only needs to leave that dog home alone twice a month, I might be leaning down the pathway of trying to support that dog with a situational or event-based med. We'll talk about what that means in just a couple minutes. Versus if I understand that this is actually a dog who has generalized anxiety and noise phobia and I might not make as much headway with my separation anxiety going down a situational support strategy if we're actually seeing other emotional disorders that are contributing to how that animal shows up during those periods of separation. So I'm looking to make sure I understand reasonably the full scope of that particular animal's issues. I'm also asking questions about how easy is it to get that animal to take meds. The reason this is important for me here is that if I'm leaning on a situational med, again, maybe it's that dog who only needs to be left home alone once or twice a month, I am depending on that owner to be able to give meds reliably, typically 1 to 2 hours prior to the departure. If this is a dog that's really tricky to medicate, what are the odds that that owner is going to get to that 2-hour point pre-departure, can't get the meds in, is stressing, now the dog is spiraling and they have to leave. The owner has to go in that particular scenario. And now we have an unsupported animal on our hands. Versus if we were able to create a consistent daily medication administration routine, would that give us a little bit more buffering on the off chance that there is an actual departure where we're not able to get meds in that day? Maintenance meds will still be having a lasting effect, even if we happen to miss a dose here or there. So really important detail, even within that caregiver present or owner present condition. If I use the same line of inquiry, thinking about the departure routine, how much advance notice does that owner have to be able to give a situational med or to be able to predict and prepare for that departure? And within that advance notice, is there chaos? Is it on a routine schedule? All things which, especially for our anxiety patients, can have a significant impact on how well they adapt to those routines, or whether the chaos makes managing their anxiety or distress that much more challenging. I also like to ask some questions, both in terms of the departure routine, as well as we'll see when we get to the greeting sequence here too. What have you tried? What sort of response have we seen to appropriate behavior modification or BMOD strategies? Not because I'm saying, well, you got to do your training first, although that's helpful. I'm really asking the question more to understand how much of the work are we asking the medication to do? If I've got an owner who's doing all the things and they're barely making a dent, then I'm really going to have to potentially have a more aggressive med plan to be able to do a lot of the heavy lifting, versus a dog who's been partially or significantly responsive to BMOD. I may not need as profound of interventions in order to see additional clinical improvement. And we'll come back to the drug choices here in just a couple of slides. Same idea, thinking about the period of time when the dog is actually home alone. What are they doing? And of course, I'm using these descriptions from the owner to not only understand my baseline, to then be able to assess back to understand whether or not our medication actually made a difference, right? Just like we would look at our baseline lab tests, implement treatment, and then compare to see if we made a difference in whatever it is that we're treating. This is our baseline data. So making sure we've got a reasonable understanding of what that baseline looks like. And for some of the medications that we're going to be talking about in just a couple of slides, some of them have side effects. And depending on what the animal is doing at baseline, there may be drugs that I'm choosing specifically to leverage side effects as part of treatment. I'll give you some examples of that as we get into it. In other cases, I may be looking to avoid side effects if I have certain conditions or certain patterns, and I'll point those out as we get there as well. One of the other things I'm looking for in this isolation or separation condition is how long? How long does that animal need to be left alone, and how frequently? That's going to give me a better sense of whether I think a dog who is left home alone twice a month for 2 to 4 hours, well, that dog could probably be managed with a situational med protocol, assuming there's nothing else there that we're trying to treat. But a dog who needs to be left home alone 6 or 8 hours at a time, or maybe somebody's coming home at lunch, but the overall period of alone time that day is pretty significant. And if it's happening more than 3 or 4 days per week on some variable schedule, that gets really tricky to manage with situational meds only. So that may skew me more in the direction of a maintenance medication approach. And of course, even within those questions, I'm really not pushing necessarily, but pushing for the answer to find out, are we actually limiting the number of departures as much as is practical for this particular family or caregiver? Knowing that the best treatment for separation anxiety does actually include not leaving the dog alone unless we're actually doing that through controlled training sessions to actually onboard coping skills for isolation or separation. So absolutely, we need to leave the dog home alone if they're going to adapt to that skill, but we need to be able to leave them for long enough and frequently enough that they can actually handle it and build a skill set or a set of coping strategies around that. And if we're not leveraging that, gosh, then we're asking a whole lot more of our medication to be able to make clinical progress. The last of these 4 time points here is the greeting. What's the level of exuberance or the quickness with which that animal perhaps gives a big shake off or a stretch or gets back to their normal resting baseline level of arousal? Again, a measure of just how much work am I asking the meds to do versus the rest of our management and training plan. Similarly, response to BMOD during that calm greeting. And lastly, how long until we have to leave again, right? And that may be relevant for an owner who says, oh, it's only 4 hours at a time, but it's a quick turn. I'm gone for 4 hours. I'm home for a 45-minute lunch break, and then I got to leave again. Either we're talking about a full 8-hour departure there, or we've got to be able to get another situational med on board. Again, what's the complication factor? What's the likelihood we're going to be able to manage with either situational or medications for an individual animal? These are important details to try to understand what support that animal needs. Not just what's the diagnosis, what support does that specific animal and caregiver combination need in order to see clinical improvements? Now, assuming we've answered all of that, what do we have available in terms of treatment options? Now, we certainly have 2 FDA-approved meds, and we'll talk more about which categories these drugs fall into here in just a couple of slides. But these are the ones that we know we have available for daily use. Both have been studied in the treatment of separation anxiety. Both have an FDA label claim, and to varying degrees, we're targeting serotonin plus or minus norepinephrine, depending on which of these drugs we're talking about. And we know that they work, but there are other options as well. And so when I'm really trying to ask this question of what sort of support does the patient need, I'm really casting that wide net to say, are we able to minimize panic through medication or other strategies when we truly can't avoid leaving them home alone? Are we reaching for medication or other strategies to be able to enhance that dog's response to the BMOD work that we're doing? Are we using medications as a direct intervention, even for when the pet owner is at home? Or are we looking for strategies that the owner can readily implement when they're there? And lastly, before we get into the actual pharmaceuticals, I do want to mention a product that's available on the market. Full disclosure, this is a Zoomedeca product. It's a Zoomedeca webinar. I want to be honest. This is supported by Zoomedeca. I'm here because I use this product in my practice, not because, well, the other way around, right? I want you to trust that this is something I actually use and recommend within the practice, but I want to introduce a device called the Calmer Canine to you if that's not something that you've already seen. Now, I will tell you one of the technical glitches today is that I can't get the audio to go through, so I'm going to play the video and you're just going to listen to me sing along in the background as a way of understanding exactly what this video would share for you. So this is me and Dr. Adam Chrisman on the DVM 360 stage with his dog Capone. You can see that Capone is wearing kind of a funny looking little contraption there, right? So this is Capone wearing the Calmer Canine device. It fits around around the sort of the neck and the base of the head, but it's attached to a harness that's actually really comfortable for the dogs to wear. When it's appropriately positioned, it sits right up near the base of the head, and at least in my experience, unless I've got a dog with really significant handling sensitivities or other aversion to specific handling, they tend to tolerate this actually really, really well. It's a device that we can put on and immediately go right to work. Turn the device on. It doesn't make noise. It doesn't have a vibration, but it does use that TPEMF technology, so targeted pulsed electromagnetic field technology, very similar to the technology in the Assisi Loop or the Assisi Lounge or some of those other devices that you may be familiar with from a pain control standpoint. Different technology. You can't just use that and put it on the back of your dog's head and have it work. It is different, but it's very, very similar. And typically what the treatment looks like utilizing this particular device is 2 15-minute sessions per day. So 2 sessions per day, basically the doctor prescribes, sit with your dog for 15 minutes, put this device on, turn it on. It is something that can actually be handheld as well. So it fits on the vest, and that's generally recommended to make it a little bit easier for everyone, but it can be handheld as well for whatever reason, if that's a particular concern. The treatments are done when the owner is home, so it's something that they have the ability to do. The actual skill level to be able to do that is way easier than some of the other treatments that we have available where there's a more complicated behavior modification plan in place. I'm not saying that this is necessarily a replacement for that, but it's a lovely adjunct for those clinical cases. And so as I'm thinking about some of these particular details, I've shared some of this information with you already, knowing that those 2 15-minute treatments over a 4 to 6 week period of time is typically considered one course of treatment. Some dogs, we do want to repeat that depending on their clinical response, or perhaps they responded and at some point in time we start to see some degree of regression, but it's something that absolutely can be used ongoing. A couple additional details here. Although we do say, 4 to 6 weeks is treatment, in the clinical trial that was done using this device, some of those dogs did start to show a clinical response even in the first week of treatment. So it's sort of nice to be able to get some of that momentum going forward. I'm not necessarily saying that this is a replacement for medication, but it is something, especially for a lot of my clients who are looking to be able to use more holistic based approaches and looking at not only the pharmaceuticals, but other treatments. This is at the top of my list. I'm also reaching for this in cases where I'm doing other pharmaceuticals and behavior modification, and perhaps we're not seeing the level of clinical improvement we're looking for. This is a great adjunct to be able to incorporate in as a really intentional therapy. So if that's new for you, I'm happy to answer any questions in the chat. Turn you loose talking to the Zoomedeca team as well. And with that, I'm going to get on to some of the pharmaceuticals, some of the things that we're going to be talking about today to really understand in answer to that question of what sort of support does the animal need. How do we decide? What sort of options do we have? How are we choosing between them? Now, as we start to go from here on in, there's a lot of data on the slides. There's a lot of information that I want to be able to share with you. I can get going a little fast. Feel free to grab screen captures on whatever device you're watching on, throw some questions in. Those are all things that we have the ability to actually sort of tease out as we're going through this. So with that being said, maintenance or situationals. I've given a little bit of a teaser on this already, that if we have infrequent, short, predictable departures, I may be able to manage that animal's separation anxiety with a situational med. That might be trazodone or a benzodiazepine or clonidine or gabapentin. I may be able to do that. However, with all of those caveats that I mentioned, if I have a difficult to medicate animal, if the departure schedule is somewhat random, or it's got a short window of time from when the owner decides they need to leave to them actually being gone, sometimes it's really tough to manage with situationals. In those cases, or if I have frequent or unpredictable departures, or perhaps I'm treating other concurrent conditions where I'm looking for a broader sort of perspective on that medication plan, I'm going to be looking more at the maintenance meds. The nice thing about these is that, of course, once they're onboarded, 3, 4, 6 weeks or so on average, then we're going to get more of a steady state effect versus having an on-off sort of effect like we get from our situationals. Now, keep in mind, this doesn't have to be an either-or scenario. Most of the medications that we're going to be talking about can be used in combination. And so it's something where typically what I'm telling folks in most cases, if we're going down the maintenance pathway, pick one. There are a couple of combinations we can use, but for the most part, entry level, getting started, one from the maintenance category, and then figure out what sort of situational support that animal might benefit from, if at all, or vice versa, right? One maintenance, potentially multiples even on the situational side. Now, what I also want to mention as we get started here is that even though I said, yeah, we've got these 2 FDA approved drugs to be able to choose from, there's a lot of data out there about what these different drugs do, which neurotransmitter systems, which amino acids are we targeting. There's a lot of data, but it doesn't always point in consistent directions. We might even be looking at 2 different studies that say, well, this one works. No, wait a minute, this one works. What I'm going to try to do as we go through the individual drugs here, starting on the next slide, is to understand how we can make some really informed choices, either based on the neurotransmitter or the amino acid or the system that we're trying to work on, or perhaps the side effects that we're looking to achieve or avoid, or understanding the maintenance versus situational approaches. All of these things will factor into making an educated decision about what to prescribe. And then we have to see what happens, right? I have to be able to have that baseline to be able to come back to say, did it work? Did it do what I wanted it to do or not? And that's the very last bullet point here, that individual patient variability. Every dog is an N of 1, and we'll have to be able to see exactly what's working. With that being said, what are we choosing between in our choices? I'm going to go down the maintenance medication pathway first. These are the ones I mentioned. We've got 2 of those FDA approved drugs to be able to choose from. But you see a few more things on the list here, and I've got them divided out on this slide based on whether they're an SSRI, a TCA or tricyclic antidepressant, or an SNRI, serotonin norepinephrine reuptake inhibitor. We're going to talk about each of those in a little bit more detail here in just a second. But the thing that really differentiates some of those medications from one another is, what are they targeting? This is a Venn diagram that I ran across from a study years and years and years ago, basically looking at what are some of the more common patterns, not just the diagnoses, but some of the patterns that in some of the attributes of a particular animal's condition, or the elements of their behavioral repertoire that may be more likely to be affected by certain neurotransmitters. So if we look at serotonin up in the upper right, we look at things like impulsivity right in the center of that circle there. Impulsivity, you see compulsion, you see repetitive or stereotypic behaviors. You also see appetite listed there as well, something that's highly relevant for some of our SSRIs. On the other side, we look at noradrenaline or norepinephrine, using those 2 labels interchangeably here. And here we look at signs more things like vigilance or distractibility or interrupted focus, as we see with the word concentration there. You'll notice that anxiety sort of bridges between both serotonin and noradrenaline or norepinephrine. And that's because anxiety can have a lot of different mechanisms. So we may have to look at that picture to say, are we seeing anxiety that looks more like a serotonin responsive condition? Are we seeing anxiety that looks more like a norepinephrine responsive condition, especially with things like exaggerated startle responses, especially hypervigilance, more of that chronically worried, nervous patient? I'm going to be thinking more norepinephrine. Spoiler alert. We'll come back to that in the next slide. When I'm looking first at my SSRI medications, as the name would say, we're looking at that right side of the Venn diagram, looking at things that are more likely to be targeted by serotonin, impulsivity, hyperarousal, quote unquote, reactive dogs often fall into this particular category. And because we're talking about maintenance therapies, we have 3 different medications that we can choose from. There's actually a lot more than 3, but if you get reasonably comfortable with these 3, you're going to have a pretty good handle on what you have available to you. Now, keep in mind, as we circle around the globe, these aren't always the first 3 choices. There are some medications that are easier or more challenging to get in various parts of the world. So if this list doesn't look completely, exactly right for where you practice in your corner of the world, take what I'm saying for what it's worth with these categories, and I suspect that we can have some conversations as well about some other attributes for other meds. But again, this is a great starting point. The first one on this list, generic fluoxetine or brand name Reconcile. This is one of those 2 drugs that we have available to us as an FDA-approved maintenance treatment for separation anxiety. Keep in mind, the number 1 side effect that we see with either fluoxetine or Reconcile is loss of appetite. That could be helpful if I had an animal that got hyper-aroused around food, or perhaps one of those concurrent conditions was more of a resource guarding with high-value food. A little bit of anorexia, as long as we're not seeing GI upset or nausea, could actually be really helpful. However, if I'm trying to manage my clinical condition of separation anxiety using any form of food-based reinforcement, either at the time of departure or as part of my training mechanisms, fluoxetine could actually point me in the wrong direction. Or if I had a dog with a clinical history where the appetite was already somewhat inconsistent at best, that might also make it difficult to get meds in and all of the consequences that go along with that. So keep in mind, love fluoxetine or Reconcile for a lot of my patients, but keep in mind there are some trade-offs. Same thing can be said for paroxetine, not as so much on the anorexia or appetite suppression side of things, but here is the first time I'm going to mention the anticholinergic side effect profile. So going back into the brain archives here for just a second, anticholinergic side effect profile is typically that acronym of SLUD, S-L-U-D, standing for salivation, lacrimation, urination, defecation, which means as a side effect profile, dry mouth, dry eye, urine retention, or potentially constipation. Now, those could be bad things or things that we're trying to avoid, or if I have an animal who's more affected by loose stools as a consequence to stress, or when they're more stressed, we actually have hypersalivation as a clinical sign. It may be relevant even in the early days of treatment before I see the full clinical expression of my medication. I may be reaching for a medication actually to leverage that side effect profile to better manage that condition. So anticholinergic side effects, we're going to see that on one of the next slides as well for a couple of other medications, but it's certainly relevant here for paroxetine. Sertraline, or the generic of Zoloft on the human side, tends to avoid both the anticholinergic side effects as well as that anorexia side effect, and it's generally well tolerated. With that being said, if I have more of the impulsivity pattern that we see here with the serotonergic medications, I personally don't find I get as much of an impact there from sertraline as I would paroxetine or fluoxetine. So if I have that more quote unquote reactive patient, I may not be reaching for sertraline first unless I'm really trying to avoid those side effects, in which case it may be a great option to get started. So educated sort of guess and or recommendation based on what we're seeing with these individual patterns. Leaving the SSRIs for just a second, we'll come back to dosing in just a couple of slides here, I promise. With the TCAs, or the tricyclic antidepressants, or the SNRIs, The biggest difference from what I were just mentioning with the SSRIs is that we're now targeting serotonin and norepinephrine. So we've got both the upper right and the upper left side of that Venn diagram as a way of trying to address multiple elements of that particular animal's behavioral patterns. So especially if I have a clinical history that includes more generalized anxiety, more hypervigilance, difficulty with sustained attention. Oftentimes the owners may describe them as highly distractible or difficult to hold their focus enough to be able to get some momentum through training. These might be red flags where some norepinephrine influence could be helpful. Just like the SSRIs, these are maintenance therapies. And there are three here that make the short list for me at least. Clomipramine or clomicalm being the FDA-approved treatment, again, in the TCA category. It's been with us for a very, very long time. And just like with the paroxetine medication that we saw in the previous slide, both this one and amitriptyline are going to have some of that same anticholinergic side effect profile. So if that's something that we're trying to avoid or something to leverage, that may allow us to narrow in or rule out some of these options. Of the drugs that we're talking about here in terms of our maintenance impact, amitriptyline is going to have the least impact of all of these on serotonin. There is some impact on serotonin, but much, much less from a significance standpoint compared to the other drugs. Now, venlafaxine, or on the human side, it's a generic of Effexor, is an SNRI, and it's sort of a new kid on the block, so to speak, for our maintenance meds in the veterinary space. It does have variable side effects. We've got a couple of research projects that have come out in the last 2 to 3 years or so. Overall, the side effects are pretty comparable to what we would see with our other SSRIs or TCAs. Full disclosure, in my hands, I actually feel like I get a lot more frequent side effects that require me to onboard venlafaxine way more slowly than I do the rest of these medications that we're talking about. Not all of my colleagues agree with me, so again, take that with a grain of salt, but if that's been your clinical experience, I'm here to corroborate that. I like it, and some things that we have to remember about that one, it may be harder to onboard for some patients. And the thing to remember about this particular SNRI is that at the low end of the dosage range, it functions more as an SSRI. We have to get to the high end of the dosing range to really start to see the clinical effect on norepinephrine. And so for clients who tend to want to be a bit more conservative in the dosage range, but you're reaching for a drug that you want that dual neurotransmitter effect, you're going to have to push to the mid to high end of the dosage range to really have it behaving in that way within that animal's body. With all of that said, doses. I know that's what we all sort of wait for. Okay, just tell me what to do. Tell me what to prescribe. Trust me, I'm the exact same way. So for the most part, these are standard recommendations that you can pull out of some of the more recent formularies. Now, I will tell you one of my favorite formularies is the one from the Handbook of Behavior Problems of the Dog and Cat. The most recent version of that was edited by Dr. Lisa Radosta. I think they did a really nice job with the edits, especially including the updates to the formulary. So for those of you who are working off an older edition or perhaps looking at other resources, some of these numbers might look a little different than what you're accustomed to seeing. Some of the things that we've learned over the years is that for the drugs like paroxetine and sertraline, they often work better as a twice-a-day med rather than a once-a-day med. And you'll see that represented there with the Q12 recommendation or option there. You'll also see that for fluoxetine, while we typically do use that as a once-a-day medication, if I'm seeing any degree of side effects, whether that's sedation or anorexia as that most common one, we can often get away from those side effects by splitting that dose into a BID dosing schedule. Whereas for the other medications, we're talking about that dose, either Q12 or Q24. In the fluoxetine literature, we're basically saying this is the per day dosage, and you can give that split or all at one time, depending on what we're trying to accomplish. Now, before I leave the SSRIs and the TCAs and the maintenance medications here and move on to some of our situationals to round out that side of the conversation, I do want to mention a couple of things about kind of the process of transitioning from one medication to the next. It's one of the most common questions that I get when I'm doing vet to vet phone calls. through the practice. We schedule those for up to about a 30-minute window of time to be able to answer whatever questions you have about the management of that particular case. And I get this all the time. We started out with fluoxetine. We're not in love with what we're seeing. What next? How do I transition? What do I transition to? What do we do? So I am thinking about that here by really trying to understand some of the guidelines that I'm looking at. Now, keep in mind, one of the most common responses you're going to get from a behaviorist when you say, what do I do? We're going to say, it depends. It depends on what? What does it depend on? So for me, it depends on the things that I've listed here. If I have urgency, meaning I have a patient who's really, really struggling, they're on drug number 1, I need to get them to drug number 2, I may not want to take weeks and weeks and weeks to do a taper and a washout and then a reintroduction of the new medication. We may go as fast as stop one, start the next. When I was in veterinary school, no way we would have ever done that. It was like, no, we have to taper. Now, keep in mind, if you're not tapering, some animals will experience what we refer to as discontinuation effects. And it can be really rocky for some of our patients. You may choose to do it anyway because of the urgency, or if we really need to maximize that animal's clinical response. The thing to keep in mind in those scenarios, one of the things to keep in mind is if we make that rapid transition, let's say I'm going from paroxetine to sertraline as an example. If that animal shows an adverse response 5 to 7 days into that sertraline or drug number 2 treatment course, I'm actually going to have a really hard time as the clinician trying to say, was that the loss of paroxetine or drug number 1, whatever it happened to be, or was that a side effect to the initiation of drug number 2? Both of those timelines are happening along the exact same window. So how can I tease that out? It's hard, right? I'm going to lose some of that data, some of that clarity by doing it that way. In other cases, if I want to be able to get that data, I can do a much more gradual taper, washout, and then introduction. Sometimes I'll do that if I've got a patient that might come in with a history of, well, she's been on fluoxetine for the last 4 years. None of us can even remember why we started it in the first place or whether she still needs it. Cool. In that category, I might then go down that pathway of doing a taper to evaluate what does that dog look like as they come off, to then either say, cool, we now have rationale for keeping them on it if it's working, or we may have a better idea of what a medication needs to be able to do, and I can make an informed decision for that stage in that particular animal's life as to what would be an intentional choice to reach for in that particular moment. So all of those things get factored in for individual patients as to how we're going to handle that transition pattern from one particular case to the next. Now, as we think about those medications, that's the maintenance side of the thing. Again, there are others, but those are the core ones that we're looking at. And as we think about what we're going to be potentially augmenting or using instead, if we're going down the situational style of treatment here, you see some of these now highlighted in orange. And what I'm going to be looking at here, especially if I'm doing any sort of situational medication trial, this is going to be true for all of the highlighted options here, is that what I'm going to typically advise for my clients is that I'm going to give them a range. It's going to be something along the lines of, here's your 100 milligram trazodone, give half to 1.5 tablets as needed 60 to 90 minutes prior to stressful event, or something to that effect. I want them to do a low dose trial, not when they're leaving the dog alone, not when they're in a stressful situation, not when we're seeing other signs of fear, anxiety, stress, arousal, any of those things. I first want to confirm tolerance of the medication, tolerance to a low dose. Then we can evaluate, does it actually seem like it makes a difference? Because for some of our situational meds, if we have a dog that is not tolerating that particular medication, we could see paradoxical excitation. We could see agitation. We could see an elevated version of that animal's normal baseline. I don't want that to happen when that dog is left alone. I want to know that at baseline. So in the ideal world where all of my clients follow all of my instructions, we do the situational low dose trial to start and then work our way up through doses in the fear, anxiety, stress situation to evaluate clinical efficacy. And then we can determine duration of action based on how well that drug is working. Now, the thing that I love about situational meds, including the first one we're going to be talking about with trazodone, is for the most part, what you get is what you see. What you see is what you get. Like, you give a dose, you wait 2 hours. That's what that drug looks like for that dog on that day. It's unlike the fluoxetine or Prozac type medications where we're needing to go down that weeks and weeks and weeks to evaluate clinical response before we know what we're getting. So if we're doing something like trazodone, I absolutely give a dose, see what it looks like, keeping in mind that in the human side of prescribing, where we have way more data even than we do on the veterinary side, the most common usage is as a sleep aid. It's a dose-dependent sedative with some anxiolytic properties to it. And so we're unlikely to see that level of ataxia that we see with things like acepromazine. And I'm grateful to say that we really don't have any significant cardiovascular impact for our patients when we're using this particular medication. But it's not always a particularly potent anxiolytic for patients who are truly in panic mode. So if you're trying trazodone and you like it because it's well tolerated, but you're perhaps not getting the effects you're looking for, we're going to have some other options to try along the way. Now, just as I shared before when I was giving you some of the doses on the maintenance medications, some of those from that formulary, which a question popped in for me in the Q&A. What was the formulary? It was the Handbook of Behavior Problems of the Dog and Cat. It's an Elsevier publication. The most recent editor of the editor of the most recent version is Dr. Lisa Radasta. So again, Handbook of Behavior Problems of the Dog and Cat, Dr. Radasta, Elsevier. Formulary, it's my favorite. I basically prescribe right along with that for the most part. I make some little variations along the way, but what you'll see here is the trazodone dosage listed there. Now, if you were prescribing right when trazodone came out on the market, we were typically looking at a dosage range of 3 to 7 mg per kg, up to Q12 was kind of where we started. Now we're looking at dosage ranges up to Q8, because that's how long it actually lasts for most of our patients, and potentially those pseudo maintenance doses, regular usage up to 12 mg per kg. And for situational uses, we're seeing significantly higher doses when we're using it truly just as a one-off. Now, trazodone is a great drug for a lot of things. It's not the only drug that we have available to us. We also have clonidine, which is an oral alpha-2. So everything you know about dexmedetomidine, for example, in the clinic as an injectable alpha-2 or transmucosal alpha-2 is going to apply here as well. Primary impact on norepinephrine, most impactful in those cases where we're trying to blunt some of that sympathetic nervous system activation that happens during that sort of peak. Animal hits the accelerator on their arousal, and we're seeing them spiking really, really quickly. Clonidine is often a really nice choice to be able to use as an oral, at-home, pre-departure sort of a medication. I do like to do this one, especially with those situational trials, and I will typically ask my clients to check a heart rate, teach them how to do that. Obviously, they can't check blood pressure quite as easily at home, but at least getting a heart rate so that I know a little bit more about how that animal's cardiovascular system is responding to that particular medication, especially if they call up saying, I gave the dose, but she's really flat out. I'd love to know what the heart rate is. Ideally, I'd love to know the blood pressure too, but at least the heart rate to start. So I tend to do that with my clients whenever I'm going down the pathway with either clonidine or Celio, which is one of the commercially available transmucosal dexmedetomidine products that we have available. Now, today we're talking about separation anxiety. This is a medication that's labeled for the treatment of canine noise aversion, but it can be used this is something that we can absolutely use pre-departure. The thing to keep in mind if we're using something like Celio as a pre-departure medication is that it typically only lasts about 2.5, maybe 3 hours, which may be great. If we're only leaving a dog at home alone for 1 to 2 hours, this may be perfect. We put it on board, it takes effect in about 15 to 20 minutes. It lasts for 2 hours and then it's gone. That may be perfect, but if you're looking for something that's longer duration, this probably isn't going to be the slam dunk we're looking for. This is oral transmucosal, and the The syringe, which has been modified from the original version, does take a little bit of education to make sure that the clients understand how to be able to administer that without risking a potential overdose of the medication. Not as much of a big deal for a big dog, but if we're talking little dogs, want to make sure they're only getting as much medication as we're really intending to give them. Now, I want to spend a minute or two here talking about benzos. Back in the day, as I now get to say, back in the late 1900s, when I came into the veterinary space, benzos were what we were using. It was diazepam, it was alprazolam, or acepromazine. That was it. That was before we had clonidine, before we had Celio, before we had trazodone readily available in the practice. We were using benzos and send them out the door like candy, right? Well, at least that was my experience of practice. And they're great. I love benzos for panic. I love benzos for situational anxiety control. Love, love, love. Obviously, all of the caveats that go along with them being a controlled substance, the need to test them so we're not getting any sort of polyphagia or paradoxical excitation or behavioral disinhibition. Of course, we need to be able to do that. And don't forget that they're in your toolbox. The number of patients that I see coming through now, both for separation anxiety as well as for other conditions, other diagnoses, where we've tried clonidine and trazodone and this and that and gabapentin and this, and there's not a benzo to be found, right? Don't forget that they're in there. Now, the dosing, this is standard straight out of that formulary. I got another question in the chat. I'm going to repeat it more slowly this time. Handbook of Behavior Problems of the Dog and Cat. Handbook of Behavior Problems of the Dog and Cat. I would throw it in the chat if that was enabled. You're just going to have to type really quickly. Editor on the most recent version, Dr. Lisa Radosta, R-A-D-O-S as in Sam, T-A. It's an Elsevier publication. This is straight out of that formulary. So go to that, take a look. And again, keep in mind that some of these are shorter acting, some of them are longer acting. Some of them, like diazepam, we may get a little bit more sedation. Others, clorazepam in particular, tends to be better tolerated if we have any degree of hepatic dysfunction or if we have any level of concerns about geriatrics or pediatric usage for benzos. I tend to go with that one as the preferred option. With that being said, leaving the benzos behind, we also have gabapentin available as an option. Now, a couple of things to think about as we're thinking about gabapentin or pregabalin. Kind of, again, another sort of new kid on the block. We've got that labeled product, Boncat, for feline stress relief, especially travel-associated stress. But gabapentin is absolutely a popular medication in the veterinary space. I love it. And recognizing sort of what it does or doesn't do is a really important, in my opinion, important thing to be able to look at to make sure that we're using it appropriately. Now, gabapentin can have effects on pain. It can absolutely have effect on situational or generalized anxiety, making it a reasonable adjunct to be able to use for our purposes here as a separation anxiety medication. We also know that while it's probably not potent enough to be functioning as a standalone anticonvulsant, it does have at least a slight effect on seizure threshold. Again, not thinking about that as an adjunctive to seizure control, but especially if we look back at some of those SSRIs or TCAs or SNRIs, and we're looking at maintenance therapies, we can absolutely see a negative impact on seizure thresholds when we're using maintenance antidepressant medications. Not all the time, but it's in there as a possible side effect. So if I need to reach for medications where at worst aren't going to move me closer to seizure threshold, benzos are a great choice. Again, going back a slide, gabapentin or pregabalin is a great choice there as well. Now, huge dosage range for gabapentin. Typically, at least when I was in practice, when we were thinking about pain control, we were initially starting 5, 10 mg per kg, Q12. Let's see what we get from that. When I'm using it for situational anxiety relief, even if I'm doing it up to 3 times a day, I'm in this range of 10 to 30 mg per kg. Situationally, 10 to 50 mg per kg is reasonable. I will hear reports of using 60, 80, or even close to 100 mg per kg of gabapentin. Not straight out the gate, mind you, But if we're seeing sequential improvements within that animal's response, or we're not seeing clinical effects from others and gabapentin is well tolerated, there will be times where I will start to titrate that dose significantly higher. Now, as I started with gabapentin, I mentioned I want to make sure we know what it does and does not do. When we're managing separation anxiety in particular, I need to be mindful that both trazodone and gabapentin can both be moderately sedating for some of our patients. And so in those cases, if I have a drug that may be sedating, I have to be mindful, just as we've talked about things like acepromazine over the years, I want to make sure that I'm not just masking or suppressing the behavioral expression of anxiety. I want to be sure that I'm actually getting an anxiolytic, comfort improving sort of an effect, right? That's an incredibly important detail. So really being able to evaluate that for my individual patient to make sure that it's doing what it is that I want it to do. Knowing that we've got lots of different usages for gabapentin, either as a pre-visit pharmaceutical or as an adjunctive as part of a multimodal polypharmacy sort of an approach, whether we're using it independently or as an adjunct. Now, there are so many other options available, and we're going to talk a little bit about supplements here in just a quick second. But what I want to stress, even before I go on to that, is when I think about these drugs that we've been talking about, right? So if I go back to that dosage chart for just a second, and I'm looking at these drugs like trazodone, clonidine, Celio, the benzos, gabapentin, all of those individual medications, for the most part, they actually play pretty well with one another. Now, the sort of, I guess in my head, I would say the obvious sort of exclusion there is I'm probably not in most cases going to be using clonidine and Celio in the same patient. I'm not going to double up on my alpha 2s. But for the most part, if I get a partial response to trazodone and a partial response to gabapentin, as many of you know, we might call that trazopentin or gabadone or gabatraz or whatever your shorthand is in your practice. Yeah, it's absolutely something that we can use those synergistically to be able to use lower doses of each to get a more significant response in response to the combination. So those are absolutely things that we can do. I'm typically going to be doing some combination based on clinical efficacy and those situational trials to find a combination that's working best for the situational control in combination with a maintenance med, again, picking one from the maintenance list rather than multimodal approaches as we're talking about here from a situational standpoint. You'll notice as well that acepromazine is on this list within the situational meds, but it's not highlighted here. There's a reason for that for me. Will I use acepromazine? Yes. When my goal is control of motor activity, and I've already done the absolute best job I can to have that positive impact on the anxiolytic effects, that my patient is as comfortable as possible. And then if I still need some degree of true sedation or motor control, then I might reach for a small dose of acepromazine to top them off. I am not reaching for acepromazine as a standalone medication. It's a question that I haven't gotten for a while. As we're seeing more popularity of the chill protocol and seeing what acepromazine does in combination with gabapentin, with melatonin, plus or minus with trazodone on board, I'm getting a lot more questions of, can I use more acepromazine? Is that okay? Or is that still kind of an out of favor sort of a thing? Generally still out of favor, but in combination might be helpful, right? So we've got a lot of ways to think about these options based on what it is that we're trying to accomplish. Now, taking me back to where I was, more than pharmaceuticals. As I mentioned, even with that lead out with the Calmer canine device, we're not only looking at pharmaceuticals to be able to manage these patients. I'm looking at their specific needs. What am I doing from a management standpoint? What am I doing from a behavior modification standpoint? Am I starting first with supplements or other sort of over-the-counter products to be able to kind of get us moving in the right direction while we evaluate the response to behavior modification? If it's a more urgent case, I may be jumping right into pharmaceuticals. But I love being able to utilize some of the products that are available on the market, understanding what their active ingredients are and how we can use them, either as a start here first, or potentially as a, we've got moderate improvement from our other therapies. Could we get just a little bit more? right? So I'm going to look at it in a couple of different directions as a way of utilizing these products. And when I think about some of the ones that are on the market, we've got the VetraScience line, which I very much appreciate. I love the Soliquin products, Elevet as a CBD product, Zilkene. I love the pheromone products, both from Seva as well as some of the other manufacturers. I love Angzitane from Virbac, the same company that makes Clomicalm. I love them all for individual patients. And that's the thing that I really try to stress when I'm thinking about some of these options, is that they all work some of the time. And so having an idea of what I can expect to get from each of these interventions to be able to really try to make an informed decision about what I'm actually going to reach for. That's really the main thing that we're looking at, to be able to do this in a really systematic, informed, thoughtful way. Thinking about those 4 conditions that I mentioned, what are the questions that we're asking about what it looks like when the owner is home, when they're leaving, when they're gone, when they're returning, both to inform our baselines and check back to make sure that we're actually making a difference, as well as to choose medications or supplements or adjunctive therapies for the patient we have in front of us. One of the most common questions that I get from practitioners, I'll give a lecture, something like this, and somebody will come up afterwards and like, so I heard all that. Yeah. I know it's complicated. It depends, blah, 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 blah. But what's your favorite protocol? What's your favorite drug for separation anxiety? I'm like, you weren't listening. No, I say that in jest. They absolutely were listening. And yet we all kind of want to have that kind of go-to protocol. I would say for a lot of the cases, at least that I see coming in, I see the greatest popularity with fluoxetine and trazodone. Does it work? Sure. It does for some patients, absolutely. But if it's not working, I want you to have a framework, a toolbox, an algorithm, if you will, to be able to say, cool, that didn't give me what I was looking for. Let me take a closer look at that patient. Is this serotonin versus norepinephrine, at least based on the patterns we're seeing? Did I go down the maintenance pathway? But God, now that I'm thinking about it, we absolutely need some situational support on there too, or vice versa, right? Really think about the support that the individual patient needs. Now, with that being said, we're going to be moving into at least a brief Q&A portion. I've got some questions that have come into the Q&A box on my end that I'll be taking a look at here in just a quick second. Before I transition into those questions, and there are some good ones in there, which I love, I want to do just a quick little shout out. Again, as I said right at the beginning of the webinar today, I wouldn't be here today. You wouldn't be here today. I don't know what you'd be doing otherwise, but you wouldn't be here in this webinar listening to prescribing algorithms about separation anxiety if it wasn't for the support of Zomedica. They do have a tie-in here with the Kelmer Canine device. I love that. It allows me to work really synergistically with them as a company, as a sponsor. And I love some of the other products that they've got available, not only the things that are sort of most similar to the Kelmer Canine in terms of that PEMF technology, but a whole lot of other products that, again, I'll leave it to the reps and the rest of the team to be able to get you the information you're looking for there. But again, I would not be here without their support. So thank you to Zomedica.